So it looks like the numbers are about stable now. They're not massively increasing, so we'll get started. So welcome everybody to our third supporter session of the year. Some of you might remember me from the previous webinar, but for those of you who don't, my name is Shadia and I work at Spinal Research as their Clinical Research Network Manager. Today we're so excited to have Dr. Monica Perez with us here. She's an internationally recognized leader in spinal cord injury research, and she's joining us all the way from Northwestern University in Chicago, where she's currently working as a professor of physical medicine and rehabilitation. She also holds the title for scientific chair for the Arms and Hands Lab at the Shirley Ryan Ability Lab. Prior to joining Shirley Ryan Ability Lab, Dr. Perez received a degree in physical or physiotherapy, and later in her career, she served as a professor at the University of Miami's Project Cure Paralysis. She's studied neural mechanisms contributing to the control of voluntary movement for the past 15 years. Now her research aims to understand how the brain and spinal cord contribute to the control of movement, with the goal of using this information to develop more effective rehabilitation therapies for those with spinal cord injuries. Her area of research mainly investigates from a neurophysiological point of view and uses a combination of different techniques, including transcranial magnetic stimulation, magnetic resonance imaging, or MRI, electrical stimulation, and activity-based therapy techniques. So without further ado, I'll leave you in Monica's capable hands to talk to you about Hebbian stimulation and its applications as a non-invasive approach to advancing spinal cord injury recovery. Over to you, Monica.
Hey, thank you very much for the nice introduction, Shadia, and to Spinal Research for inviting me to give this webinar. It's really an honor to be here and to have the opportunity to discuss some of our results, and hopefully we have a good time at the end for questions. So as Shadia mentioned, I'm a physical therapist. I have been working for the last 15 years, a little bit over, on trying to understand reorganization in the central nervous system, and importantly, try to use these principles of reorganization to develop better treatments. So in the United States, I'm in Chicago at the moment. In the United States, we have over 18,000 of new cases of spinal cord injury every year. And unfortunately, there is not FDA treatment at the moment for spinal cord injury. Importantly, rehabilitation of spinal cord injury largely relies on traditional therapeutic approaches. And I'm going to focus my presentation on trying to address how a protocol that we are using based on neurostimulation is trying to overcome those problems that we have with traditional rehabilitation approaches. So what factors could potentially limit the outcomes of rehabilitation? One of them could be the lack of personalization. Most of the approaches that we currently use in rehabilitation are exercise or neurostimulation, but many of these programs uses a one-size-fits-all approach. They're not customized for individual patients or participants. The second problem could be that we spend a little bit of time in optimization of clinical trials. So we complete the clinical trial, and if we see an effect, we spend little time in trying to make that effect stronger and stronger. So I'm going to show you how we are trying to do that in our laboratory. Another important approach is that we focus largely in short-term gains. That means immediate improvements after the clinical trial or after rehabilitation. But what happens later? What happens in the chronic that people with chronic injuries can continue to improve with rehabilitation and proper approaches. And finally, we have incomplete understanding of neural mechanisms of repair. So in our laboratory for the last several years, we have been using neurostimulation, a protocol that aims to enhance functional restoration. And I'm going to go through all of these items one by one and tell you what are we doing to overcome the problems that we have with current rehabilitation approaches. So how do we approach the lack of personalization with our approach? So we're using a protocol, a neurostimulation protocol that is based on principles of spike timing dependent plasticity. And we use the Hebbian hypothesis, and this is personalized to individual patients. So we have good evidence that when two axons are connected to type of neurons, if actually we aim to induce activation of one of the neurons a little bit before we activate the postsynaptic neuron, we can perhaps enhance voluntary output and the output of synaptic transmission. So you will wonder, how can we do that in humans? So in humans, there are several ways of using this approach non-invasively. And this is a cartoon that shows you what we're trying to do. So we can stimulate connections from the brain that actually send impulses to the spinal cord. And also we can stimulate connections from the periphery on peripheral nerves, and signals travel back to the spinal cord. So we aim to target the connectivity that is present in the spinal cord by two sides of neurostimulation. And by stimulating the brain, or in this moment, at this moment, we're bypassing the brain, we stimulate axons, descending axons at different sites, and I will show you how we do that. We aim to understand and to target connections that are residual connections after the injury, and aim to make those connections stronger. So how do we do that? Over the years, we have been using neurophysiology, and these are some of the measurements that we are taking in our laboratory in order to make estimations of how do we stimulate these two sides within the central nervous system. Today, we're bypassing the brain. We stimulate descending axons at the level of the cervicomedullary junction, that is behind your neck, or we can also stimulate descending axons at the level of the thoracic spine. We also stimulate peripheral nerves that innervate different muscles of the arm and the hand, and different muscles of the leg, the upper part of the leg and the lower part of the leg. So we can use that with simple techniques that are widely used in electrophysiology in humans. So what are our efforts to avoid using one principle that fits all, or one treatment that fits all individuals, or with spinal cord injury? So our efforts aim to understand how this type of stimulation, for example, behave or is effective in improving elbow flexion force and elbow extension force. And this publication is online already. This is Carly Butler. This is our PhD student that just graduated. The paper is recently online. So what Carly did is to compare the ability to improve voluntary output in elbow flexors compared to elbow extensors. And after spinal cord injury, the triceps, the elbow extensors, are quite difficult to recover. This was the aim in the rationale for the protocol. So Carly, as I showed you before, took some physiological measurements to understand when do we stimulate the brain and when do we stimulate a peripheral nerve, the proper timing. And what she found is very interesting is that with the same type of stimulation, these are responses coming from the primary motor cortex. The responses in the biceps brachii grow much more. They increase in amplitude much more than responses in elbow extensors. In this case, the triceps brachii. So we need perhaps many more pair of pulses, or much more intensity of stimulation in order to target connections to the triceps compared to connections to the biceps. And this is quite important because we have to optimize our protocols according to the muscle representation that we are stimulating. And this is individual data, and you can see that the triceps, the size of the responses after the stimulation increase, but not to the same extent as for the elbow flexors. So another and comparing how do we use the stimulation to target the hand representation, also more proximal muscles. And you can see that we can see larger effect of the stimulation in a hand muscle. This is in blue right here, and in red is a more proximal muscle. So if we want to improve more proximal muscles that are more affected by the injury, we need larger number of pair pulses. So we need another type of parameters in order to make this stimulation much more effective. So this is what we are doing in order to personalize the intervention to individuals with spinal cord injury. So there is another area we are trying to optimize the effect of our clinical trials using this protocol and using Hebbian stimulation. So we have completed at the moment 3 randomized placebo-controlled trials. The first one in the first trial was published in 2020, and we use only 10 sessions of pair or Hebbian stimulation with exercise. In the next clinical trial, we use 20 sessions combined with exercise. And in the last combinatorial approach, we use a medication, and I will show you the results, combined with stimulation and exercise rehabilitation. So why is so important to optimize the effect of clinical trials? So this is the exercise program that we use when we target muscles of the arm. We ask individuals to work in precision grip to try to target corticospinal responses and involve the corticospinal tract. We also ask individuals to perform gross grasping behaviors and generalize arm movements. For the lower limb, we focus on overground walking, treadmill walking, and stairs, as well as other lower limb exercises. So in the first clinical trial, what we found is when you use pair-associative stimulation or Hebbian stimulation for 10 sessions, we can observe changes in voluntary activation, some electrophysiological changes, but the behavioral effect between the group that received the real stimulation or the placebo was limited, suggesting that the dose of the stimulation perhaps was enough to reach the central nervous system, but it was not too strong to cause changes in voluntary motor output between the groups. So we increased the dose of the stimulation, and we did 20 sessions instead of 10 sessions. And we target at the same time several muscles at the same time to make the effect stronger. So here we found a stronger effect. We observed differences in voluntary motor output. This is differences in the 10-meter walk test. Is the speed of walking was faster in the group that received the real stimulation compared to placebo. And also individuals improve more in terms of electrophysiological outcomes and in terms of their ability to perform voluntary motor output with different muscles that we targeted. The main question is, did they reach the minimal clinical important difference? So even though we observe these changes and individuals walk faster after the real stimulation, only a few people reach the minimally clinical important differences. So for us, that means that we needed to increase the dose and keep optimizing the protocol. So we went to 40 sessions, and in this trial, we stimulated the upper limb and the lower limb, and we're very happy to report that with this dose of stimulation, most patients reach the minimal clinical important difference in the 10-meter walk test. So this red bar shows you the improvements after 10 sessions. So people with spinal cord injury became a little bit faster. After 20 sessions, a little bit more. But after 40 sessions of this combinatorial approach, exercise and stimulation, the majority of individuals reach the minimal clinical important difference. And this is quite remarkable because that gives us an idea of how can we optimize a clinical trial and how can we optimize the dose of any treatment, in this case, our Hebbian stimulation. Importantly, the improvements with this non-invasive approach were quite similar to improvements that have been reported in the past with invasive approaches that require epidural stimulation that we could do with non-invasive approaches if we target the approaches properly. So we also observe improvements. This is the test of the results of the sensory scores of the INSCI exam. After 40 sessions, there was an improvement, and also in the motor scores of the INSCI exam, after 40 sessions, we observed some improvements and increases in motor scores. And importantly, quality of life also. We observe improvements in ambulation, self-care, bladder difficulties, and bowel management. And this paper is online if anyone wants to go in more depth about the results from this type of stimulation and protocol. So as you can imagine, the idea is to try to continue to improve and to continue to optimize the effects, even though there are some improvements, but we continue to make the protocol stronger. In this case, we decided to use a combinatorial approach that uses foraminopyridine. This is a medication, it's a potassium blocker that enhances excitability at different sites within the central nervous system, and also Hebbian stimulation and exercise rehabilitation. So this is our last placebo-controlled randomized clinical trial that we completed recently. The paper is online also, and you can see that we're using 40 sessions as before. That was the minimum of sessions that show some improvements in terms of reaching the minimal clinical important difference. And individuals took 10 milligrams of foraminopyridine, receive almost 1 hour of stimulation, and then 1 hour of exercise rehabilitation. And they were randomly assigned to the placebo group or to the group that received stimulation. This was quite encouraging because now we were able to reach the MCID, or the minimal clinically important difference, after 20 sessions, which we never saw in our clinical trials before. So this is the group results. You can see here that after 20 sessions and 40 sessions, this is the group that received the placebo stimulation. And we needed, without the medication, you need 40 sessions in order to observe or to reach the MCID. But with the medication, we were able to see some patients reach the MCID after only 20 sessions. So this is quite encouraging that you can continue to make the protocol stronger and continue to improve functional restoration. So this is the raw data. This is individuals, all the individuals who participated in the placebo group, and this is the group that received the real stimulation. And you can see that after 20 sessions, only one of them reached the MCID. If we use foraminopyridine, 60% of them after 20 sessions reached the MCID. After 40 sessions, 60% of individuals reached the MCID, but 80% of them reach the MCID. So the medication really helped us to move the bar and to get to the minimal clinical important differences with less number of sessions. And these are all individuals who had chronic, incomplete spinal cord injury, but quite pronounced deficits in functional restoration. So I'm going to show you some videos also that show you some of the effects that we have been able to achieve over the years. This is on the left. You can see this is a participant with chronic cervical incomplete spinal cord injury. And I wanted to pay attention to his level of function before and after 40 sessions only of this stimulation protocol. And at the beginning of the trial, he couldn't maintain his balance. So all these individuals have descending connectivity, but you can see that they're quite limited in their ability to control lower limb muscles and their ability to walk in this case. So this is an individual who is performing. We ask him to walk as fast as possible. This is before the trial, and this is after 40 sessions. And he received the combinatorial approach with foraminopyridine. And you can see that after 40 sessions of this combinatorial approach, he was in the real group, not the placebo group. He was able to walk almost 3 times faster. So it's amazing the effects of these possible therapies in neurorehabilitation. So this is another participant. She had a cervical spinal cord injury also. And you can see that after the stimulation, she has large difficulties before the stimulation in grasping an object. And you can see that after 40 sessions, she was able to grasp the object with less difficulties. So we're extremely happy with the results, but as always, we continue to try to make this protocol stronger and stronger. And we have found over the years that this is extremely important and might contribute to some of the effectiveness that we have seen until today. So I mentioned at the beginning that we usually focus on short-term gains. Usually you are in a rehabilitation hospital, you receive exercise, and we don't follow people over time, which I think is something that we have to think as a field. What approaches do we have, and how do we aim to target individuals who have chronic injuries? Because all these videos that I have shown you now are coming from individuals with chronic injuries. So there is a large potential to continue to improve rehabilitation outcomes. So we follow a few people, and you can see that they receive 40 sessions, 80 sessions, 120 sessions of Hebbian stimulation with exercise rehabilitation. And you can see what is interesting is that the more sessions that you do, different muscle groups are showing some recovery. So that's quite interesting. If you see here, this is the average size of responses from the primary motor cortex. This is the maximal voluntary motor output. It continues to improve over time. And this is the motor scores also, how they continue to improve over time. So it's important, I think, to focus on long-term gains and to understand the effect of these therapies over the longer period of time. So I'm going to two videos actually of individuals. This is one of our participants. This is the baseline assessment before the protocol. He couldn't control movements of his legs. After 40 sessions, he was able to gain some control. He had a chronic injury. And after 120 sessions, when he left the hospital, he was able to live with a walker, and he had a chronic injury. So I cannot emphasize more how important it is to work not only in short-term gains, but continue to improve the outcomes of rehabilitation. This is another example, an individual. You will see how he walks before the stimulation protocol, after 40 sessions and after 80 sessions. And I want you to pay attention to this strength control. And so the more sessions, people continue to improve in the protocol. But as you can imagine, it's quite difficult to come to Chicago and do 120 sessions. So this is why accelerating the protocol and making the protocol stronger, we we have found that it's feasible to find similar effects, but with less number of sessions. Last part of the presentation is, which is one of the most important ones, and we have spent times and years in trying to understand the neural mechanisms of this protocol. I didn't show you most of the evidence, but happy to send you material as needed. Is extremely important. So at this point, what we have decided to do to improve the mechanisms and to improve the knowledge on mechanisms is to focus on measurements and assessments of participants with spinal cord injury. And I'm going to show you this example, 2 participants, and I want you to think about, when you see this video, who of these 2 participants will be able to walk after the same clinical trial, after a similar personalized protocol. This is participant number 1, and we asked him to walk, and this was what he could do at that point, at that time. And this is participant number 2. We asked exactly the same question, and participant number 2 was also not able to walk. So I want you to think about which of these 2 participants you think will actually benefit more from the protocol. It's very difficult to see now. If you base only this assessment in clinical outcomes, it's a little bit more difficult. But today, we have technology that actually allow us to assess descending connections from the brain. So participant number 1. So participant number 1 received 80 sessions of our protocol, and he was able to remarkably show improvements in locomotor outcomes. Okay, and this is extremely important because when we assess connections from the brain to different muscles, different lower limb muscles, we found strong connections present, even though he was not able to walk at the beginning of the trial. So I'm going to show you the second participant, and the second participant also received 80 sessions, and you can see that after 80 sessions, it was very limited. Okay, even though these 2 participants look quite similar at the beginning of the trial, it was very limited. There were some improvements, but it was much more limited. So the main difference between these 2 participants is their level of residual connections before the trial. And that sometimes is easier to observe with more sophisticated approaches like brain stimulation to assess the pathways and those connections. So what we decided to do in order to really understand the mechanisms and also optimize this protocol much more to a larger extent, now that we have seen that with optimization, actually we can see better responses, is to move the protocol from humans into an animal model, into rats. This is a collaboration with Dr. Martin Odega from Chicago, Professor Jonathan Wolpa, and Sig Gaikwad, our postdoctoral fellow, Matthew Niehaus, which is our PhD student. With Professors Odega and Wolpa, actually, we were able to move the protocol, the same stimulation protocol that we are using in humans with spinal cord injury, into a rat model. The paper is now online. I encourage you to look at the paper because here we describe how do we stimulate the leg motor cortex in animals and peripheral nerves, and how can that elicit a similar type of changes in excitability as what we see in humans. We are currently using the protocol in animals with spinal cord injury and trying to combine this with molecules, cells, different type of therapies in order to accelerate and facilitate clinical translation. So I want to thank our lab members, especially the people. I'm going to take a last minute to highlight the people that contribute to the work, the ones that are still in the lab. Dr. Bing Shen, who completed the combinatorial approaches of Hebbian stimulation, exercise, and foraminopyridine. And with Bing right now, we are running another clinical trial where we are increasing the dose of neurostimulation, not only neurostimulation, but foraminopyridine to see if the effect could be larger. Carly Butler, Carly just graduated. She completed her PhD, and she was the student who was it's helping us to understand, do we stimulate different muscles using the same parameters? For example, the elbow flexors, biceps, or the triceps using the same parameters, and it's not. We need to personalize this type of stimulation in order to get a better effect. Min Q, he is a current fellow in the lab, a postdoctoral fellow. He's also addressing similar questions as Carly, but now he's focusing on more distal muscles, the hand and the arm and the leg, different leg muscles in the leg, to optimize the protocol. Sid and Matthew are actually the people that are working together with Dr. Odega in understanding and moving this protocol to an animal model. I want to thank the funding agencies, especially in this time in history, NINDS, Veterans Affairs, Wings for Life, and the Walkabout Foundation. Thank you very much.
Thank you so much, Monica, for such a brilliant presentation. It was so lovely seeing all those videos and learning about Hebbian stimulation, something that we don't get to hear about so much. Now, something I should have mentioned at the start really is that there is a Q&A box across the bottom of your screen on the toolbar. We welcome everybody to submit their questions. I will do my best to pick them out. We're obviously going to prioritize those from members of our spinal cord injury community. So please go ahead. We've already got some coming in, so I'll get started. Manu asks, does this technique also work for complete spinal cord injury?
Yeah. So if we define complete with the clinical exam, okay, we usually, if we have an individual with AIS or ASIA A and B, we have to do a physiological exam. The majority of injuries, spinal cord injuries in humans, are anatomically incomplete. So the only way to assess if there are some residual connections that are still viable or working to some extent from the cortex to different muscle groups is by doing this type of assessment. So we have used the protocol in people with AIS A and B, but they have already also received an electrophysiological outcome to ensure that they have some residual connections. And unfortunately, the clinical exam itself is not sensitive enough to detect that level of connectivity. So yes, we have used the protocol in individuals with AIS A and B, but ensure that the physiological assessment reveals that there are some connections available.
Thank you. Paul asks, what's the value of the minimum important clinical change in the 10-meter walk test?
Yes, that's a great question. I think, the community, we all try to find ways of characterizing how relevant, how critical, how important are these improvements in functional restoration. What usually we ask our participants is how relevant is for you, okay? How relevant is the ability to improve your walking speed or balance, does it allow you to gain more independence? So I think these values are standardized values, they're helpful, but I think in my experience over the years, the most important is what the participant feels, yes? I still remember many years ago at the University of Pittsburgh, when we started using this protocol, I was very excited showing graphs, responses that are growing and are larger after the stimulation. But I realized over the years that the most important is the participant. Do you feel a difference? And we're very blessed that participants want to return for stimulation. So I think this is the important part. I think more than having a number or a classification is personal. Is, do you feel that this is making an impact in your life in any way? Yeah.
Great. Kareem asks, have the trials taken into account fluctuating blood pressure readings for incomplete SEI patients?
Yes, that is a great question. When we started the clinical trial with foraminopyridine, because we were combining a medication with the stimulation, we were very strict in controlling blood pressure before and after the stimulation, and also before and after the medication. And since it's such a low dose, we haven't had problems with blood pressure. Most people who enter the trial are stable, but we haven't had any problems. We haven't looked at the effect if this stimulation actually can improve to regulate your blood pressure. We haven't looked at those type of symptoms, but we have not seen major changes before and after either the stimulation that, for example, your blood pressure might raise, or after the medication for aminopyridine. Seems to be quite stable.
Great. And a lot of people are asking questions around access. So Steve says, this looks very promising, but what are your next steps and the timeline to roll it out to more people? Is there a product that can be used for the rollout?
Yes, so we are making strong efforts to use the protocol widely at different sites, centers throughout the country, and hopefully throughout the world. We started training sessions. Please, if you're interested in learning about training centers, send me an email and I will send you some information back. We had a large training session before the Society for Neuroscience last year in Chicago. We are planning more webinars and in-person trainings for clinicians or researchers or people working in the clinical field who wants to use the protocol. The protocol, the measurements that we use are accessible. Accessible means that neurologists use this type of conduction velocity, this type of test. So there is a little bit of training to do for part of the measurements, but the majority of the protocol is easy to train. So we're actively working. So send me some information, please, if you want to receive information about training dates and when it will be happening and where they will be happening. We are actively training people. And the one in Chicago last year was extremely successful. So people are asking for how can they get access to the protocol? How can I use this protocol in my institution? So send me questions and I will send you all the information that is needed.
Oh, that sounds great. And Erica asks, how often were the sessions performed? When they have those 80 sessions, how often do they do them?
Yes. So we asked participants, the majority of participants came from outside of the Chicago area. So between 3 to 5 times a week. We don't have evidence that if you do this for less number of days, this will be effective or not. But we think between 3 times a week or 5 times a week, that was the dose that we used in our previous trials, and that was effective. So it could be that if you use this 7 days a week, could be even more effective. But for now, 3 to 5 days a week seems to be the dose that most people could tolerate well, and that most people could, be able to participate in the protocols.
Just to let everybody know, we have still got like 30 open questions. We've got loads of questions coming in, and I'm trying my best to keep on top of them. So some of the questions are around 4AP. People are curious. So John asks, does 4AP negatively affect muscle spasticity or bladder, bowel, and sexual function?
Yes. So in the first clinical trial, I didn't put all the results. The paper is online now. It's in the Journal of Brain. We measure sensory function in all our clinical trials. So this is the first time that we see with 4-aminopyridine combined with the stimulation and exercise, we saw large changes in sensory function. So and spasticity seems to be reduced. What we see at the beginning of most of the trials is that the spasticity increases, okay? And for us, that means that we are stimulating neural pathways. And over time, over the 40 sessions, it starts to decrease. We have in every trial, we methodologically follow up this type of side effects and these symptoms. So I think there is a potential to decrease spasticity. Our studies with looking at the mechanisms of spasticity also suggest that there is an imbalance between loss of corticospinal drive and increases in reticulospinal activation or inputs. So strengthening exercises are quite important for this balance. So we have seen effects. The second randomized placebo-controlled trial with foraminopyridine we're almost done. We just enroll a person from Canada. This is the last participant, and the trial is already ongoing, so we're completely blinded. It's going to take some time until we open the trial and understand if a second dose of foraminopyridine is more effective than a single dose. But this is what we are working at the moment.
Okay, sure. And we've got some people asking about home use. So can this technique be translated into practical use for at home?
Yes, that's a great question. I think at the beginning, most likely, this is what how the vision for this protocol. Most likely, you will have to go to a clinic or a hospital or a center to set up the parameters. After that, you might be able to use the stimulation at home. This is not ready yet, so you can go directly to home. Okay, but this is a way in which we're training people to understand and train others how to use the stimulation, and then you could potentially at some point receive the stimulation at home or go to a center of excellence, go to a center where actually you can receive the stimulation. Right now we have people coming almost every 6 months or 8 months for a booster. We call that a booster, for more stimulation if it's needed. So we are actively working on avenues to make this more accessible. So please reach out if you want to learn more about the next efforts to make this more massive and available for everyone.
Sure. And Anissa asks, how soon after injury can something like this be administered?
Yeah, so all our publications, all our clinical trials are in individuals with chronic injuries, and we consider chronic. Initially, we tested 1 year and above and more, and now in the last study, we tested people with 6 months post-injury and more. We have used also the stimulation in people with subacute injuries, let's say 20, 30 days after the injury. We haven't published yet, but we have preliminary data that we could have some effectiveness, but there's no publication yet. So as you can imagine, in the subacute phase, we have to be quite careful because there might be spontaneous recovery also that contributes to the improvement. So we are planning a randomized placebo-controlled trial in subacute injuries, but we haven't done it yet. But the preliminary data suggests that there should be some effectiveness, but no publications yet.
Okay, sure. And in terms of comparison, Wayne asks if you can comment on other spinal cord stimulation therapies, for example, the RX versus the Hebbian approach.
They're different, okay? And I don't want to be biased also to one or another one. I'm just going to try to talk about the literature and what we know, okay? So both protocols aim to target the spinal cord. The mechanism is fundamentally different of how we do that. My suggestion is be very critical about the design of clinical trials. Okay, we need clinical trials with proper design, randomized placebo control to really understand the effectiveness, the magnitude of the effect of an intervention. So I'm not going to comment. We haven't made comparisons, and this is not my goal. My goal is to make people aware that we have to be critical as a community with our protocols, with everybody else's protocol, that we need randomized placebo-controlled trials to actually properly assess the effectiveness of any type of therapeutic approach that we're bringing to the community.
Okay, sure. And there's lots of questions around pain. So there's two sides to it. I think one is the treatment itself painful whilst having it done? But secondly, has the treatment led to any improvements that people are experiencing with regards to pain?
Yes. So that's a great question. Every time we show movies of people receiving the stimulation, there are movements of the arms or movements of the legs. And the reason why that happens is because we stimulate peripheral nerves. So we stimulate supramaximally the motor neurons. So we elicit strong voluntary contractions. We don't use high intensities to activate the majority or most of the motor neurons. This is in the surface. We have been doing this since 2012, since the first publication in spinal cord injury, over and over and over. So the protocol is very well tolerated. These are procedures, the peripheral nerves are being stimulated in the clinic for neurodiagnostic purposes. So the part that is a little bit more difficult is a stimulation of descending motor pathways. So in order to address that and to have a better possibility of success, we have replaced magnetic stimulation by electrical stimulation of descending axons. So we have made many approaches, for example, large electrodes to pass currents that activate descending pathways. So we have been able to recruit subjects and people keep coming back for the trials. So I will say the protocol is very, very well tolerated. And with other approaches like exercise and proper medications, it seems to be that combination. Try to find the best combination to make the effect stronger and more powerful.
Oh, and in terms of length of injury or length since injury, Julie asks, will this work for someone who's had an injury for 40 plus years?
Yes, yes. So we have tested people with chronic injuries, and some of them have had 10 years post-injury, 20 years post-injury. So this is why I think it's extremely important. I mentioned at the beginning 4 aspects that will be important to consider when we think at why our treatments are not as effective. What do we need to do in order to make these treatments more effective? And one of them is to consider long-term effects, okay? Because we have the capacity, the potential to continue to elicit some form of plasticity, depending on how do you define plasticity, but some form of change, either a physiological change or a behavioral change, years and years post-injury. So I think it's important to think not only soon after the injury, but have a program, a protocol, a way in which we can continuously involve people in this type of therapies, because you wonder if 120 sessions are better, 80 sessions are better than 40, 120 sessions are better than 80. So we should continue. We should, and actually right now we're limited to research. Okay, we're limited to funding if the funding agencies allow us to do that. So I think with a few others, we're working on approaches to try to make this more accessible for people and not only based on research basis or insurance company basis. Yeah.
Okay. So Rowan, who's a PhD student at Imperial, has asked, what's the main reason for using cervical over cortical magnetic stimulation?
Yeah, that's a great question. What we have found is that with non-invasive methodologies, several years ago, we published there are ways of making indirect evidence or inferences about eye waves. When you use cortical stimulation, and with cortical stimulation, I mean magnetic, transcranial magnetic stimulation, how you activate corticospinal axons is transsynaptically. So you activate a series of descending volleys that go down to the spinal cord. So the temporal dispersion is increased because you lose axons, you lose myelin. So with indirect methods, we were able to look at the publications. We were able to show some increased dispersion. So by replacing cortical stimulation, cortical magnetic stimulation with electrical stimulation of the axons, we have found that perhaps it's easier to elicit responses because we decrease the temporal dispersion by activating axons more directly. So happy to send you more publications. I give you an example. If you use transcranial magnetic stimulation in an individual with AIS or Asia A and B, you might see no response whatsoever. You use electrical stimulation of axons in the same individual, and you might see connectivity. So it's quite important to think about those differences.
Okay, sure. Moving on to a slightly different section of the population, some people are asking about the treatment protocol and its suitability for the pediatric population.
Yes, yes, we have not used the protocol in children yet. We have colleagues that have been asking and colleagues that are using either transcranial magnetic stimulation or peripheral nerve stimulation in children. We haven't. I think it's an avenue. It could represent an avenue at some point, but we haven't, unfortunately. I think the youngest of our participants had been 18 years old. I think for children, you could stimulate pathways. The most important part is to make sure that there is a game involved during the protocol, that we engage them perhaps with virtual reality or other modalities to make the session, because you receive 1 hour of stimulation to make sure that you maintain their attention and that they enjoy the 1 hour of being sitting down with performing the stimulation. So I think it's feasible, but we haven't made any attempts yet to move into children.
Okay, sure. So, so far we have answered about 20 or so questions. We've still got 30 left, and it's really, really difficult to pick them all out. So thank you everyone for sending in all your questions. I am doing my best to filter them all. One of the things that people are repeatedly asking is, how do we kind of get in touch if we either want to participate in a trial like this, or if we want to find out more about your protocol? I think people are really
Yes.
keen.
You can send me an email, okay? I have a coordinator. We can send you information. Right now, the trial that we're ending is 2 doses of 4-aminopyridine combined with stimulation and exercise. So the placebo, everyone receives a stimulation and exercise, and the placebo is the medication. So depending on the outcome of this trial, we hope to open the trial by the end of the year, earlier next year. Every summer until now, we've been having systematically a new clinical trial. So depending on the results of this clinical trial is what will be next. Okay, are we going to continue to use 2 doses of 4-aminopyridine, only a single dose? Of course, we will use the stimulation with exercise, but how do we keep building? We are also making efforts to combine 4-aminopyridine with another medication, which is an NMDA receptor. We're running those studies so to see what will be the best protocol for the next clinical trial. So please send me an email if you want any information, and I will put you in touch with our coordinator, and she can give you the times, the dates, and the current studies that we're doing, running in the lab. We appreciate anyone who wants to learn more, and we can send you some of the publications by email.
Right, and presumably this information can be found online either on the Shirley Ryan Ability Lab website or perhaps clinicaltrials.gov. Does that sound right?
That sounds correct. If you go to the Perez lab in Shirley Ryan Ability Lab or Northwestern University, our publications if they're not updated, but most of them are there. So that's another avenue to get more information about the protocols.
Okay, great. And before we let you go, for our final question, what would you like to achieve in the next 3 years, and what would that mean to people living with spinal cord injury?
Well, stronger outcomes in less time. I have been working in the field of spinal cord injury for over 15 years. We need to keep going. And I want to tell people with spinal cord injury that we are actively responsible working on making these protocols more effective and available for you. So reach out, because we also need people who can help us to test these protocols. So I think there is a new era that is coming up. I think combinatorial approaches are key, and combinatorial approaches, not only medications, but perhaps cells, scaffolds with neurostimulation, exercise. We are strongly, I didn't talk about that because we don't have results yet, but I think that's the new era for rehabilitation in spinal cord injury.
Great. Thank you so much, Monica. Thank you to those of you who submitted questions, and I am sorry if I wasn't able to get to yours. If there's any other information that we can share with you, please feel free to drop us an email on research@spinal-research.org. We'll do our best to find the answers to your questions. Once again, thank you, Monica, for joining us today. It's been such a useful session, as you can tell by all the questions that we've received.
Thank you very much for having me and for inviting me. It's been a pleasure. Thank you, everyone, for all the questions, and reach out. Thank you.
Absolutely. Thanks, guys. We hope to see you at the next one in December.